Nursing Case Management and Congestive Heart Failure by Shauna Priest, Joy Martin Spriggs, and Kelly Murphy. Patient and chronic illness. DS is a 68-year-old Caucasian male hospitalized for a congestive heart failure exacerbation. DS presented to the emergency room with shortness of breath and complained of increased peripheral edema. He has been married to his wife, MS, for over 50 years and has 3 children who check up on him periodically. DS is a retired auto mechanic and would be considered to be of middle-class socioeconomic status. He is also insured under Aetna insurance. DS was initially diagnosed with heart failure last year. In addition to these diagnoses, he has the following chronic conditions: hypertension, type 2 diabetes, arthritis, gout, obesity, and high cholesterol. Medical treatments and nursing diagnoses. DS will be going home with the following meds: metformin, atenolol, hydrochlorothiazide, and simvastatin. In addition, he's been instructed to continue checking his blood pressure daily, wear compression stockings to help with his edema, will be provided supplemental oxygen as needed, is to be taking his weight daily, and is to adhere to a strict sodium restriction of 1.5 grams per day and a fluid restriction of 2 liters per day. In addition to the medical diagnoses, DS has the following applicable nursing diagnoses: deficient knowledge, fluid volume overload, decreased cardiac output, impaired physical activity, self-care deficit, chronic pain, ineffective tissue perfusion, and activity intolerance. The nursing diagnosis most pertinent to his case management needs would be deficient knowledge, and his nursing case management strategy or intervention would be providing education relating to adherence to dietary restrictions of sodium and fluid. DS will continue to receive telehealth monitoring and continued education services with a nurse educator bi-monthly upon discharge. According to Larson, telemedicine interventions for CHF clients has been shown to reduce number of nursing visits, improve patient perceived quality of life, and decrease home health care costs. Excuse me. Self-capacity in comparison to chronic illness. According to Orum's theory of nursing as cited in Alspach, self-care can be described as, quote, comprising all of the voluntary activities that individuals undertake in order to maintain their health, life, and general well-being, unquote. The capacity at which is necessary to complete these tasks may range from simple and relatively easy to complex self-care activities requiring education and refined skills and training. DS has the capacity to complete certain aspects of his self-care, but also lacks the ability, education, and motivation to complete others. As mentioned in Larson, DS shows some of the factors that render his self-care insufficient, as evidenced by his, quote, misunderstandings, misconceptions, and lack of knowledge, unquote. Self-care behaviors focused on his congestive heart failure and chronic disease conditions includes medication administration, blood pressure monitoring, compression stocking application, elevation of his lower extremities, weight monitoring, sodium and fluid restrictions, diet compliance, appointment management, and oxygen management. DS has been successful with most aspects of his chronic disease management, but has also been non-compliant with the dietary aspects of his self-care and has not been monitoring his weight or adhering to fluid and sodium restrictions. Measuring the capabilities of an individual's ability to perform his or her activities of daily living, or ADLs, can be an indication of the degree of disability with his or her disease. According to Larson, basic ADLs include personal care and basic survival tasks, whereas instrumental activities of daily living, or IADLs, include functions such as, quote, cooking, cleaning, buying groceries, doing yard work, and paying bills, unquote. According to Dunlay et al., predicting factors of difficulty performing ADLs include older age, male sex, having diabetes, having cerebral vascular disease, having dementia, anemia, morbid obesity, and being unmarried, unquote. DS exhibits 4 of these predicting factors, including older age, male sex, diabetes, and having morbid obesity. He currently has a high functionality with the majority of his basic ADLs, yet is having increased difficulty performing IADLs, such as grocery shopping, cleaning, and performing yard work. DS receives functional care assistance from his wife and children in those particular aspects of his care. Some of the barriers identified to DS's self-care capacity are behavioral, while others have the potential to improve with increased resources and education. According to the Agency for Healthcare Research and Quality, discharge from hospital to home requires, quote, the successful transfer of information from clinician to the patient and family to reduce adverse events and prevent readmissions, end quote. The ideal discharge planning model is endorsed by the AHRQ and used to help engage patients in their care. We can implement the system to identify priority areas for discharge planning with DS. Under I, we're going to include DS and his family in the discharge planning process. We will ask them questions and identify their needs and concerns about transferring home. Under D, we will discuss key areas that put patients at risk for readmission. These include asking DS and MS what their daily routines include. We will also review his medications and make sure he understands what each is for, when to take them, how to take them, and when to report side effects to his nurse or doctor. We will also go through key warning signs and symptoms of congestive heart failure that warrant immediate notification of his physician or nurse. We will go over pertinent test results and schedule follow-up appointments with his cardiologist and primary care physician. We will also make sure that DS knows when his telehealth appointments are and how to get in touch with his case manager, nurse educator, and any additional needed resources. We know that DS has had issues with dietary compliance, so ensuring that he remains on target with the goals we set upon discharge will be our priority issues. Under E, we will continue to take any opportunity during his hospital stay and encounters to educate DS and his family in his preferred language about his prognosis, discharge process, and what the next steps are for his care. Under A, we're going to utilize the teach-back method to assess how well the nurses and doctors have explained DS's condition, prognosis, and discharge instructions. If needed, we can provide additional teaching and resources. And lastly, under L, we will listen and honor to DS's goal for his own care, his preferences, and his concerns.